Hello and welcome to webinar number 2 in our Applying to Clinical Psychology series. This webinar will explore the role of the clinical psychologist within current NHS teams, giving an overview of the various duties that clinical psychologists perform on a day-to-day basis. My name's Lucy Kozlowski, and for those that don't know me, I currently work as a clinical health psychologist within the NHS, working primarily in physical health teams, mostly in children and adults, diabetes services and stroke inpatient services. And I work privately under the third wave clinical psychologist, working in terms of supporting staff, looking after staff wellbeing, and providing supervision and consultancy services. And I guess in my roles, my day-to-day duties are varied and diverse, and they tend to change in response to the needs of the team or the service that I'm currently working in and the needs of the patient group. So hopefully this will give you an overview of what the clinical psychologist generally does in their day-to-day working life, although it must be emphasised that no two roles are alike. So I'll be speaking to the general skills and duties performed, although that role may vary depending on the setting and the patient group. So when applying to clinical psychology courses, it's worth considering or reflecting on each of the areas that the clinical psychologist works in, the skills, the duties they perform, and showcasing this on the application to demonstrate a wider awareness of the role beyond clinical duties. So what does a clinical psychologist actually do? Well, let's start with thinking about some of the areas that a clinical psychologist might work in and the client groups that they might work with. So working through the lifespan, lots of psychologists work with children, whether that's in children and social services. We've looked after children with foster and adoption agencies or mental health services, child and adolescent mental health services, typically called CAMS. And the children that we might work with in these settings tend to present with difficulties around attachment difficulties, low mood or anxiety presentations, eating related difficulties, anger issues, self-harm, suicide issues, and family conflict. They may also work in paediatrics, working with children who have physical health conditions such as diabetes, cancer, cystic fibrosis, chronic fatigue, chronic pain, respiratory conditions. And the presenting difficulties here can be around management of the condition itself or adjustments to that condition, adjustments to having medical procedures done, bereavement work, or general health or general mental health issues around anxiety, low mood, anger, self-harm, and motivation issues. And similarly, in adult physical health services, clinical psychologists offer support for similar issues, generally working with individuals or couples. And they may also work in neuropsychology teams, such as stroke teams, or older adult services, offering memory-related assessment and intervention services, as well as offering psychological wellbeing support to the person and their wider family in these services. They also work in learning disability teams, offering cognitive assessments and remediation work, family support, and wellbeing support to those with learning disabilities. They work in forensic and prison services, and often these services have fairly large psychological services in comparison to other areas. And the role may involve supporting rehabilitation of people who have offended, offering psychological wellbeing work, supporting reintegration, neuropsychological assessment and intervention, family work, ward work and staff support, which is particularly important in this area. And many psychologists work within mental health services, both inpatient and outpatient. And typically psychologists working with those struggling with severe mental health presentations, such as psychosis, manic presentations, eating-related issues, as well as extreme low mood, emotional dysregulation, or frequently called personality disorders, anxiety issues and anger issues. And they also support people with self-esteem issues and issues arising in the perinatal period. And at the less severe end of the continuum, psychologists might work with people who are presenting with mild to moderate low mood and anxiety presentations in primary care and IACT services. Or they may offer supervision and support to staff within these services to enable them to provide such services. So as you can see, there's a wide range of services and populations that a clinical psychologist might work with, and I'm sure I probably missed many areas out. Apologies if I have, that's not intentional, and I'm sure there's many other roles that psychologists fill that I'm unaware of. This just gives you an introduction to some of the services that psychologists may work into and the typical presentations they may see. So clinically, depending on the setting or the service and the therapy modality adopted by the psychologist, psychologists tend to work with individuals, groups, families or wider communities, drawing from these sort of key psychological models. Generally speaking, CBT and third wave CBT are the most common psychological models drawn from the NHS, but psychologists also draw from psychodynamic approaches, systemic and family therapies, community psychology models, narrative approaches, social constructionism, person-centered therapy and humanistic approaches, and cognitive analytic therapy. And at the core of these approaches and modalities is three key processes really: assessment, formulation and intervention. And most psychologists, I suspect, would say that they're integrative therapists. They draw from different models in response to the clinical need and the service they're working in. Personally, I would say that I'm an integrative therapist, drawing from third wave CBT approaches, systemic therapies, particularly social constructionism, and narrative approaches, community psychology practices, and neuropsychology. And that depends on the clinical team I'm working in and the clinical need in front of me. I guess regardless of the model adopted, at the heart of this clinical work is assessment and formulation. So understanding what brought the person or persons or community to psychology or health services, and supporting the person to make sense of their journey and their experiences. And this can also be undertaken with communities and wider groups of people, particularly when working from a community psychology approach. Assessment is generally undertaken by a lone psychologist or a psychologist in collaboration with multidisciplinary colleagues such as mental or physical health nurses, dietitians, medics, physios, occupational therapists, and it may or may not include input from the person's family or wider social system as well. An assessment usually involves a clinical interview, but it also may involve the use of formal assessment measures, including psychometric tests or neuropsychological assessment batteries, again depending on the service and the presenting problem. And these measures help with identifying particular areas of difficulty, as well as helping to measure outcomes and progress through therapy, and can also be crucial for ensuring services receive the funding they need from NHS England. And the main aims of these assessments are to help the person or persons or community explore and identify areas of difficulty or distress, areas of strength, their reasons for attending services now, and any potential predisposing, precipitating or perpetuating factors in distress. And this information is used collaboratively with the person to explore their story, and to build an understanding of the factors that may have made them vulnerable to distress or difficulties that they might be facing at that time, factors that may have triggered the distress, and possible maintenance factors maintaining it. And this story, termed formulation in psychological therapies, is a hypothesis which is open for revision, but provides a roadmap for intervention, advising of targets and areas for change. And for this reason, for me, it's really important that formulations are contextually driven and include all the ecological levels that influence our lives. For me, drawing on community psychology principles in all areas of our clinical work can help us just to think a bit more widely about the factors that affect our health and well-being, and avoiding locating social and political problems within the individual. And this ecological model demonstrates the impact of wider socio-political systems and structures on our individual health and well-being. And also the return impact that we can have on these systems. Formulations that include these wider levels then help us to think how we can intervene and influence these wider levels in a positive way that shapes health and well-being for the better. Whilst one-to-one intervention is, of course, of significant importance, I do believe it's also important to intervene at these wider levels, offering intervention beyond the therapy room and addressing these wider socio-political causes of distress. And this intervention approach may involve lobbying or campaigning for policy change, using the evidence base to inform policy or service development, working with marginalised groups to help their voices to be heard, empowering local communities to develop psychologically informed environments, signposting to advocacy groups, or challenging the dominant narratives and discourses within a society that cause harm. Psychologists may also host group therapy sessions or psychoeducational talks, promoting psychological thinking and awareness within communities. They may also offer family therapy and systemic approaches to tackling distress, and of course offering one-to-one therapies and interventions. I think it's quite a common misconception that psychologists spend much of the day in a therapy room offering psychological therapy on a one-to-one basis, sitting on a comfy sofa and kind of having that one-to-one back and forth. And for some psychologists this may be the case. However, for others, this only makes up a small part of their day, or the intervention that they offer may reflect more of the community psychology model I just outlined. Or they may offer one-to-one intervention a bit more flexibly. For example, working on stroke inpatient services, I might offer a 20-minute consult at the side of a person's bed, or in children's diabetes services, spending time with an admitted child to the ward in the playroom. Or in forensics, you may go on a short walk around the hospital grounds to try and build rapport with a patient. So for some services, it's about offering a joint session with an MDT colleague, for example, or running a joint MDT clinic. So intervention can look very different depending on the service and the style of the psychologist. And the intervention offered, as discussed, will reflect patient need and therapist preference based on the formulation and their preferred modality style and their training. I think depending on the service or setting, contracted time within a team and staff resources available, the amount of time spent offering direct clinical work in this fashion will vary from psychologist to psychologist. Many psychologists often work across teams, working part-time in different teams, mainly due to wider political and financial reasons, funding factors. So some psychologists may be the only psychological member of staff in a team or a service or even a department. And so therefore their time might be quite limited within a service. So it's important for the psychologist to consider ways that psychology can effectively be maximised within such limited resources, but also of course with a community psychology hat on, thinking about how we can address these wider social political factors that limit sometimes the impact of our roles, championing the role of psychology in teams, bidding for funds and working with service developers. And challenging those wider dominant narratives around medical models of distress. But of course, that's beyond the scope of this presentation. And of course, these factors are important to consider, but at the same time, it's important to think about how we can, in this moment, work effectively as psychologists to get psychology out there in teams and to become more of a dominant approach to treating distress and ill health in our culture and in our NHS services. I guess if this is something you wanted to reflect on in the application form, It's certainly important to show awareness of some of the challenges of the role of the clinical psychologist within the NHS, but not to bring a defeatist attitude towards that, and to maybe think about ways that you've overcome some of the challenges in your work. Which I guess brings us to the wider role of the clinical psychologist beyond direct clinical work. So depending on the team and the staff and the makeup of the service, a common role of the clinical psychologist is to offer supervision, clinical supervision, whether that's formal or informal, to other team members. And this could be to other qualified psychologists, to trainee psychologists or assistant psychologists. And it can also be to non-psychology staff. Typically, the supervision offered would reflect case management or providing space for reflective practice, supporting staff, continuing professional development, as well as supporting staff wellbeing. And in health services, it's quite common to offer supervision to our multidisciplinary team colleagues, such as nurses, medics, physios, dietitians, OTs, but also importantly administrative staff as well, and to help the team to reflect on their clinical cases or their clinical interactions, and to support psychological thinking in such colleagues, perhaps using team formulation skills to help them to formulate and make sense of the difficulties that patients might be going through, or to formulate their interactions and engagement with patients. And supervision can also help staff to think about their personal processes and how these may influence the way they interact and engage with patients. And hopefully it's a containing place for staff to process their frustrations or their distress, and an empowering place where staff can think about helpful next steps to take. And many psychologists will offer reflective practice sessions for their wider colleagues, offering a space to bring any patients that the team might be feeling particularly stuck with or challenged by, and a space for them to formulate what may be occurring within interactions with the patient or their family. And again, that's why it can be helpful to include administrative staff, because they're often engaging with clients, whether that's through reception or over the telephone. Linking in with supervision is consultancy. Psychological consultancy promotes psychological thinking about a patient and their presentation, and it involves sharing psychological knowledge with our multidisciplinary team colleagues. And again, this can be conducted formally or informally, so it could be those water cooler chats, chats over the photocopier, or it could be more formal consultation in the form of case management or a case conference. It could be through running psychologically informed training or workshops for non-psychology colleagues to help them develop their psychological skills, or understanding of psychological models, or training them in brief interventions. And again, I guess depending on the team and the service you work in, and your access to other psychology colleagues, you may spend more or less time engaging in supervision and consultancy, or more or less time engaging in clinical work. Certainly for me, I would say there's a 70-30 split between how much consultancy and supervision work I engage in and how much clinical work I engage in, with 70% being supervision and consultancy, in terms of skilling up other staff and helping them to deliver psychological interventions, brief interventions, or to promote psychological engagements with patients in their day-to-day work on the ward or in clinics. And in conducting all of these duties, the clinical psychologist is constantly demonstrating leadership skills. And I know the word leadership can be a bit anxiety provoking for many assistants or aspiring psychologists. And certainly I've worked with assistants and trainees who feel anxious when faced with this word, or feel like they have no hope, they don't have any opportunities to undertake leadership duties or any examples of leadership activities. But I would really encourage you to think about all the times you've shared psychological knowledge and perspectives with non-psychologists, because these are certainly examples of leading psychological thinking in others. And leadership doesn't have to include or involve those grand statements and actions. It's the small everyday activities that lead change in others or promote change in others. Again, those water cooler conversations, those car trips with a colleague to a patient's home, delivering a training workshop, or co-facilitating groups or clinical sessions. These are all ways that we're modelling and promoting psychological thinking and practice in others. Typical leadership activities of a clinical psychologist on a day-to-day basis might include running training and workshops to develop psychological thinking and skills in colleagues, service development projects and programmes, working closely with service managers and department heads to promote psychologically informed changes to services, applying for funds and bidding for grants and services. And for me, when undertaking these leadership activities, it's really important that the psychologist is at the forefront of changes in services, promoting more psychologically informed narratives to care. And for me, I do believe co-production is best, whether that's with patients, communities, teams or services. So any service development I feel should be done in a collaborative style, identifying Indigenous strengths and identifying service specific needs. Not applying a one size fits all model of service development, but exploring and collaboratively identifying with the team or service what their needs are for development, and finding ways that we can facilitate those as psychologists and support the team to develop in the way they feel they need to. And all of this work is adopted within the scientist practitioner model, so drawing from the research and the evidence base to inform clinical practice, whilst undertaking practice-based research. I guess the reality of undertaking research in the NHS and keeping up to date with all the latest developments is understandably tricky. And there are ways that we can work as scientist practitioners and stay up to date using the Trust Library or Open Athens, effectively using study days or the Trust Research and Development Department, and applying for grants and funding. So it's finding ways and exploring ways that we can work as a true scientist practitioner in a very busy and evolving NHS that places a lot of clinical demands on us. So that brings us to the end of the webinar. Hopefully that's given you an overview of the role of the clinical psychologist and something to think about when you're completing the application form. Do look out for other webinars in the series. We'll be delivering a self-care webinar shortly. And we also are running an Act Mindfully series, which is based on ACT and mindfulness skills for staff wellbeing. So do keep in touch. Subscribe to the channel to keep updated with new videos as they come out, and do join us on social media for an ongoing conversation. Keep in touch, keep well, and look after yourselves and stay safe, and I'll speak to you soon.